basic science research in the myocardium and published 7 papers before even starting medical school. During medical school, he continued his research interests and was awarded the Dean's Research Fellowship Award during medical school. During residency, he was awarded the Resident Award for Scholarly Activity. And then after completing residency here at the Barbara Bush Children's Hospital, he completed a Pediatric Cardiology Fellowship at the University of Utah and did an additional year in advanced imaging and fetal cardiology. He has published extensively on a variety of topics, including hypoplastic left heart syndrome and other forms of congenital heart disease. He evaluated a novel ultrasound transducer to look at fetal vascular response in uteroplacental insufficiency and congenital heart disease. And he also studied the effects of maternal diet and environment on myocardial programming in the fetal period and in young infancy. He's a national leader in the study of neurodevelopmental comorbidities associated with congenital heart disease, and that's the topic of his talk today. He served in a number of national leadership roles, including research committee chair and vice chair of the steering committee for cardiac neurodevelopmental outcomes collaborative of the American Heart Association. He's currently the vice president or the vice chair of the Congenital Heart Defects Committee of the AHA, Council on Cardiovascular Disease in the Young, and he's been invited to speak nationally and internationally regarding his research. He is also recognized as an excellent teacher and mentor, and is known for developing an echocardiogram boot camp for fellows in cardiology, and he's also noted for his great bedside teaching. So welcome once again, Dr. Miller.
Thank you, Mary. That's too kind. So, sorry for the AV difficulties and starting a little bit late. I understand I'm the last thing between the residents and their retreat, so I'll try and stay on time. It's like being the last talk at the end of a meeting before dinner. When we went to meetings. Sorry. Now the slides aren't advancing. There we go. All right, I think anyone who says they have no conflicts of interest is not telling the truth. I have a bunch. 2 of them are listed here. Chasing some fish, the sunrise over the Atlantic, and chasing some fresh tracks in the Wasatch. But I do have to disclose a lot of the data I'm going to show were supported by research funds when I was at the University of Utah, pictured there on the right. So we're going to talk briefly about the neurodevelopmental phenotype that's seen in congenital heart disease and some of the anticipated concerns. Some of the groups that we think are higher risk for worse neurodevelopmental outcomes. Dive a little bit into the data that support different clinical factors that are associated with variable outcomes, current approaches across neurodevelopmental programs across the country and a little bit around the world, as well as what we're proposing to do for congenital heart neurodevelopmental program at Maine Medical Center. So in summary, the scope of the concern is a quite variable phenotype that we see in kids with structural heart disease and acquired pediatric heart disease. Starting at birth, there are just things that you can measure that are different in kids with heart disease. So smaller head circumference, structural abnormalities, periventricular leukomalacia, or white matter abnormalities, and CNS immaturity. In infancy, you see some of the clinical manifestations of concern, so more seizures, again, changes in white matter, abnormal neonatal behavior. We worry a lot about motor skills and motor development, both for those that are stuck in the ICU and those that aren't in the ICU for as long, as well as some delayed milestones. In the preschool age, the concern for delayed motor skills really persists, and there's a lot of individuals that struggle with delayed language. And in middle school, we start to see behavioral problems, inattention, hyperactivity, poor handwriting, poor visual motor integration. And as you transition into adolescence and to adult congenital heart disease, there's increased rates of depression, behavioral problems, attention, hyperactivity, visual motor problems, again with visual motor integration. A deficit often in social cognition, which impacts peer interactions, as well as poor planning and executive function often is a big issue. So that sounds like a lot of problems, but to put it in perspective, I really like this quotation from the Boston Circ arrest trial when they had the teenage follow-up. So this was at about 16 years of age. Boston Circ arrest trial was transposition of the great arteries. They randomized the different bypass support strategies, and we're looking at neurodevelopmental outcomes. They followed them out quite a ways. And from this paper, they have the quotation that the problems are not so severe as they are prevalent. And so if you look here at the different tests, reading, math, memory tests, in the transposition group on the left there, you can see they're statistically lower than the normative group on the right, the p-values, but they're always within the normal range. So 95 versus 100, with the standard even the norms being 15. So statistically significant, but clinically, again, not so severe as they are just prevalent. But in that trial, the Boston group found 65% of patients that underwent arterial switch operation received remedial academic or behavioral services, and 33% had abnormalities on brain MRI. So even though they're not devastating injuries, if you're the parent taking care of this child, and 65% of them have remedial academic or behavioral services, it's a real impact on your quality of life. So to put it another way graphically, if I only have 5 minutes to explain neurodevelopment and congenital heart disease, I really like to use this slide. It doesn't matter that the outcome is the Vineland. It doesn't matter that this was the 6-year follow-up of the SVR2 trial. We'll get to that in a minute. But if you just look at the box and whisker plots, it really describes almost every outcome study that we have in neurodevelopment and structural heart disease, which is basically you can find one domain that you're more concerned about. So in this case, it's the motor skill. And if you look at the box and whisker plots, you can see the median is below the average. So for Vineland scores, 100 is normal, and there's 15 points plus or minus for the first standard deviation, shown in the red and the dotted red lines there. So it falls within a range, but it's statistically below the average. But what's impressive is the tails are just huge, with some kids actually doing quite well, but some kids doing very poorly by this metric. And what we're still not good at after years and years of studying these kids is which factors actually predict these outcomes. So I'll show you some of the things that we have. The other big overview summary slide I'd like to share with this is from the ICON studies. This was led by Bill Gaynor. It was a multi-center study, included over 1,700 kids from 22 institutions across the world. The inclusion criteria were cardiopulmonary bypass at less than 9 months of old, and the outcome they were looking at was the Bailey scores at 14 months of age. So again, the dotted line up top is 100. That's normal for a Bailey. Standard deviations are 15. And what this study was showing, or what they concluded, is that starting back in 1996 compared to kids that were born in 2009, we really haven't made a dent in, if you use the Bailey as a surrogate for neurodevelopmental improvement and outcomes, there really hasn't been much improvement over time, even with all the things that have changed in the operating room and the ICU. So that's a broad overview of the summary, but let's dive a little bit more into who at risk. So there's a guideline paper that was put out in 2012 that all the residents should have if you don't already. It talks about neurodevelopmental outcomes in children with congenital heart disease and recommends approaches for evaluation and management. It claims that those that are at the highest risk include, it's pretty broad strokes, neonates or infants requiring open heart surgery, whether you're cyanotic or not. So that's any surgery before a year of age. And then children with other cyanotic lesions, even if they don't require open heart surgery during the neonatal or infant period. So that'd be TEP-PA MAPCAs, maybe you get by without a bypass, or Epstein's or other hospitalization, which they define as greater than 14 days, which most of our kids fall in. Perioperative seizures associated with surgery or significant abnormalities seen on neuroimaging. So if we think about the risk related to outcomes, I like to think about a couple of different categories of how things may go wrong, as evidenced by this person here on the right. And you can think of the inherent problems with the substrate or the individual at risk, not being old enough to be on that bike, or having concerns with the genetic substrate going into the OR to carry it over to kids with congenital heart disease. There's also environmental risks, so that would include, here's the ramp, but it would include the CICU, the home environment they go to afterwards. And then there's also different things that we expose them to. In this example, it's a poorly regulated older brother, but we expose them to a lot of narcotics, we expose them to bypass. So the causes are really multifactorial, they interact with each other, and they're ongoing. So in fetal life, there's issues with substrate delivery, oxygen delivery, changes in cerebral resistance, placental abnormalities, genetic syndromes that set you up for different outcome trajectories from the very beginning. There are preoperative modifiers that likely impact outcome. That includes delayed diagnosis and kids coming in quite acidotic, low cerebral blood flow, poor oxygen content going to the brain, the ICU morbidity even before you go to the OR. Intraoperative factors, anesthesia, drugs, bypass, circ arrest. There's in-hospital modifiers, length of stay, narcotic use, kids experience hypoxemia, hypocarbia, etc. And then there are late modifiers, ongoing hypoxemia, the socioeconomic status the kids go back to, whether or not there's post-traumatic stress disorder, the parental depression, anxiety, poor nutrition, heart failure, and a lot of others. So there's a lot to go after and uncover, but for the purposes of this talk, in the interest of time, I'm just going to focus on a few that I've been interested in, circled there. So starting first with fetal life, being a fetal cardiologist, it's important that you recognize the substrate delivery and the oxygen delivery to the brain is not normal in most structural heart disease as a fetus. So on the, oops. So on panel A, there is a great review from Mary D'Onofrio if anyone's looking for a good review on fetal circulation. But oxygenated blood, remember, in utero comes from the placenta, so it comes up from the IVC there. It crosses the foramen ovale and goes right up to the head. And most of the deoxygenated blood is going out the right heart and across the ductus. But if you look at transposition just below it in panel D, all that oxygenated blood coming back from the placenta is going across the foramen, but it's going out the left ventricle straight to the body, and the deoxygenated blood is going out the aorta to the head. And in hypoplast in the middle top there, all the blood mixes, there's nothing going out the left side, and it goes retrograde across the arch. So the delivery of the oxygen is not normal. Others, including Mike Seed, have been looking at things like glucose. There's a lot of thought that actually the glucose delivery is abnormal. And so we know that even before you go to the operating room, kids with heart disease, their brains are different than those who don't have structural heart disease. This can be measured with imaging that just shows their smaller brains, both in volume and size. The brain is immature. It's more comparable to a preterm brain. And there's a high prevalence of abnormal MRIs. A lot of this work was done by Stephen Miller and Patrick McQuillan when they started looking at preoperative MRIs before these children even went to the operating room. And they showed a 30 to 40% incidence of abnormalities. So white matter abnormalities, hemorrhages, strokes, and then things that I know what the words are, but I don't really know what they mean: increased diffusivity and decreased fractional anisotropy. And those are some of the pictures on the right from later on in life. The ultrasounds are also abnormal. So this was pretty groundbreaking work by Kathy Limmeropoulos from Children's National. She looked at the N-acetylcysteine choline ratio, hope I got that right, over the course of gestation. So that ratio is on the left of this graph, and gestational age and development's on the right, and the solid triangles are control fetuses. And then those with heart disease, hypoplast in the circles, transpose in the diamonds, just show more immature brains as you mature in development. So a 36-week-old has closer to a 30-week mature brain. In the non-congenital heart disease world, there's, for the neonatology colleagues out there, there's a lot of interest in cerebral distribution and how in IUGR, for example, you can get asymmetric IUGR because of quote-unquote brain-sparing effects, where you decrease the resistance of flow to your brain, which is shown here in middle cerebral artery Dopplers. You decrease the resistance to your brain and increase the resistance to your placenta. Maybe you'll shunt more blood up there. And that's what most people think drives asymmetric growth restriction in neonatal IUGR, so outside of congenital heart disease. We also see cerebral flow changes in congenital heart disease. And a lot of people hypothesize that that is related to brain-sparing changes that the vasculature is trying to obtain. And in these studies from Anita Swatz and the CHOP group show that it depends on your type of heart disease, how the cerebral vascular resistance changes. So again, gestational age in weeks is across the x-axis there, and then on the y-axis, and both of these are just two different metrics of flow distribution. So the middle cerebral artery pulsatility index on the left and the cerebral placental ratio in the graph on the right, and the controls are in the dotted lines. And you can see over gestational age, both of those numbers kind of go up. And if you have pulmonary obstruction, they're pretty close to the controls, but if you have aortic obstruction, your resistance drops in your cerebral vasculature. And so you see those different trends over the course of gestation. But Lisa Hornberger's group in Edmonton published this study a little while ago that it might be too little too late. What a lot of people aren't talking about is, so again, this is the MCA, the pulsatility index Z-score on the x-axis. So again, a showing of resistance. So if you get more to the left in this graph, you drop your resistance trying to send more flow to your brain. But on the y-axis is the head circumference z-score. And you actually see that those that have the lowest resistance actually still have the smallest heads. Pretty crude measurement, but goes against the idea that the vascular changes are actually brain sparing. So a lot of us think it may be a too little too late type of phenomenon. And the asymmetry in growth has actually been known for a while. So these are data going back to the Baltimore Washington infant study in the 80s. We know in broad strokes, those with transposition have normal birth weight, smaller heads. Those with tetralogy, smaller in all dimensions, but relatively symmetric. Hypoplasts tend to be smaller in dimensions, but proportionally smaller heads, and cohort shown there. And in more contemporary data from the infant single ventricle trial, these are z-scores. So weight for age z-score on the top, length for age z-score next, head circumference for age z-score below. And they're all less than -1 in these normalized things, but the head circumference is significantly lower at -1.7. So we were interested in whether or not within a certain structural heart disease, was there difference in placental resistance and vascular resistance that would drive some of your outcomes. And so we looked at a pretty crude measure of placental resistance, the systolic to diastolic umbilical artery ratio, shown here on the graph. Over gestational age on the x-axis, most of them go down, which is normal over the course of gestation for that resistance to drop and the ST ratio to drop. But we had a subset of kids with this, these were all hypoplasts in Utah. Retrospectively, we looked at where those resistances were going up. And in those that had no decline in the ST ratio, so those that we thought were abnormal placental resistance in hypoplastic left heart syndrome, we found that they were more asymmetric. So the measurement here is the birth weight for age z-score minus the head circumference for age z-score. So a lower number would mean that your head is bigger than your body proportionally. So we actually thought we saw some asymmetric growth in the setting of just isolating the placental abnormality. And we thought we were really onto something because, and I'd be excited to talk a lot longer about developmental origins of health and disease and how we think that impacts outcomes, which I don't have time for in this talk, but we showed that the ST ratio was also associated with worse interstage growth. So potentially programming for worse growth overall. So interstage is the time between your Norwood and your Glenn, between about a month of age when you go home and 4 months when you come back. So we thought that was a pretty interesting finding, and we thought we'd chase it in the infant single ventricle trial data set to see if growth asymmetry predicted anything with outcomes. So a lot of measurements here on the graph on the left, you don't need to really pay attention to them. They're all asymmetric measurements. So weight for length z-score, weight for age z-score minus the head circumference age z-score at a couple different times throughout the trial. Just like that first graph I showed, the important thing of this is there's a lot in the distribution in the tails, right? So we thought there would be some signal here in those that were more or less asymmetric, maybe those that protected their brain growth versus those that didn't. We looked at another measurement of relative head growth, change in centimeters over change in kilograms. But we found no association with any of the asymmetry measurements and the neurodevelopmental outcomes that were followed at 14 months of age in this Pediatric Heart Network trial. The ones that did come out in multivariable modeling were length of neonatal hospitalization, your pre-Glenn head circumference, your 14-month height, and whether or not you were on ECMO. All right, so moving into intra-op. I think in order to look at the different variables operatively that are associated with disparate neurodevelopmental outcomes, we lean a lot on surgical trials. So for those that don't know, there's a trial called the single ventricle reconstruction trial that enrolled about 550 neonates through 15 centers starting in 2005. It was a surgical trial randomized to 2 different surgical approaches for hypoplastic left heart syndrome. And the primary outcome was transplant-free survival at 12 months post-randomization. But what this trial allowed for is it's one of the best it's not a true inception cohort, but it's one of the best prospectively studied cohorts from prior to going to the operating room, with almost every surgical variable you can think of collected prospectively by PHN centers and research coordinators. And so we followed this cohort over time. The SVR extension study followed them between 2 and 6 years of age. And actually, we just decided the trial was about to end during COVID, and then people weren't following up. We just had a call recently. We're going to close enrollment, I think, in a month now. We're bringing them back between 11 and 12 years with a primary focus. We're still looking at survival and cardiac function, but there's a much bigger focus on neurodevelopmental outcomes in this group. So the first neurodevelopment outcomes that came out related to it in this 2012 paper were the Bailey scores at 14 months of age. And you can see the psychomotor developmental index on the left and the mental developmental index on the right. Again, normal is 100. The two standard deviations are shown in the dotted lines there. Bigger impact of lower scores in the psychomotor index, just like I was talking about earlier. Motor seems to be hit harder in these kids than anything else, but there is definitely a skew to lower scores in the mental developmental index as well. But in the multivariable analyses, those variables that came out associated with worse scores were just low birth weight, neonatal length of hospitalization, number of complications in sight. So a lot of course complexity, but nothing in there about bypass, about temperature regulation in the OR, all these other things, pH strategies when you come out. Nothing came out of the multivariable models related to that. And similarly with the MDI scores, low birth weight, length of intubation, post-Norwood, number of complications, whether you had a genetic syndrome, and your maternal education. Skipping forward a few years when these kids came back for their 3-year ages and stages questionnaires, just like that original Boston Circ data I showed you, statistically lower in a lot of domains, but not horrifically lower, although fine motor is quite a bit lower than the other domains. But again, in the multivariable analyses, it was really course complexity, length of hospitalization, number of complications, whether you had vision or hearing problems or census block, and none of those operative factors. So these are from Karen Goldberg's analysis at 6 years of the SVR trial. And when we looked at these, we tried to lump them into categories. So these are a bunch of different outcomes measures at 6 years across the top. And an X is any time it fell out in the multivariable analysis for that grouping. And then we kind of lump things together. So there's some inherent factors, just like my first picture. There's some exposure factors, like what happens in the OR. There's a lot of course complexity factors that I would put under environment. But in general, an important thing to note that we highlighted in this paper, but I think gets lost sometimes, is look at the R-squared values for all of these. So again, this is an extremely well-controlled, prospectively collected cohort that we have almost all the surgical data on. And for a long time, people have been blaming all the surgeons and everything they do in the OR for the neurodevelopmental outcome for these kids. But the R-squared values are super low, suggesting our models don't really explain a lot of the variance. Which leads me to this quotation this is from a postdoc in Mark Yandel's lab that I've had the pleasure of collaborating with in Utah. And we were doing some big data projects and some EMR projects, and we threw him a couple papers to talk about the covariates that we wanted to try and link into those papers, to the analyses. And he wrote, "The more I'm reading papers on the subject, the more I witness attempt to phrase failed research attempts as a mysterious, urgent, undiscovered problem." He quotes, "In total, patient factors explain 30% of the variation outcomes. In other words, it means our approach failed completely because our data are so bad," he said, "it's so bad, and our model has a terrible fit. And it's obvious from the beginning because there's no chance that fitting a straight line can explain the complexity of human health, no matter how many bells and whistles you attach to it. It is still a straight line." And again, this is a postdoc, he's a mathematician, hasn't thought a lot about heart disease, but to me, this was really enlightening and was sort of a turning point for me to think about signal to noise. And we have really studied the things that are lower hanging fruit to study because we can collect them in the hospital, but where there are still huge gaps in understanding neurodevelopmental outcomes in congenital heart disease are all the things we haven't studied. And I want to share these data. This is not in congenital heart disease, but this is a type of slide that someone throws up, and I couldn't stop thinking about this after Stephen Miller put it up at a CNOC meeting last year, I think. And these are neonates in Vancouver, X24 to 32 week preemies, and the outcome was the WIPSI at 4.5 years. And what they did is they looked at maternal education and then whether or not you had a brain injury. So punctate white matter injury or interventricular hemorrhage. So as a non-neurologist, I think of that as just you had an injury to your brain. So the dotted lines mean you had a brain injury. The solid lines mean you didn't. Yellow, your mom graduated with a postgraduate degree. Blue, undergraduate degree. And black, primary, secondary school. And if your mom graduated from college, it didn't matter if you had a brain injury based on these data. And the other thing is we always think of the low SES as really the at-risk, but when you look at those without the brain injury, there's a bigger signal in the low SES, but really the middle SES is not doing anywhere near as well as the top SES. And this becomes a real big problem. The reason this hit home is there's a huge bias in our congenital heart disease research in neurodevelopmental outcomes. And so we're involved in a pediatric cardiac genomics consortium trial. This was just in the middle. We just did the data freeze and we're starting to analyze everything. But I want to just share with you what the SES status is of the people coming back for testing. This isn't the whole cohort. This is when we were looking at it sort of in the middle. But 60% having college or postgraduate degree and 40% making 6 figures or higher. So what I like to talk about is most of what we know about what happens in neurodevelopmental congenital heart disease is based on a huge bias of people that come back to their huge centers, that are able to come back to their big centers for extensive testing in either research trials or other settings. All right, moving on to genetics. So to put in perspective, it's important to think, we know if you have a genetic syndrome that your neurodevelopmental outcomes are going to be worse with structural heart disease. So I think it's important to back up and talk about a lot of the research with genetics and congenital heart disease is people are trying to find the genetic cause of congenital heart disease. So for those that don't think about this a lot, I just want to put it in perspective. And this is from a review article we wrote a couple years ago in JAHA, where on the big pie graph on the left, that's just understanding any genetic cause of causing the heart disease. So the big piece is 72%, we don't think we know. So maybe 25 to 30%, we think we know the cause. Of that 25%, 6% are chromosomal abnormalities. That's the top pie chart. Big portion of those are Down syndrome, then 13, 18, and Turner's. Another big chunk is CNVs, about 10% of heart disease we think is explained in these. But note you think a lot about 22q, but that's really a small slice of the pie. A lot is other or unknown. And then when people talk about genetic causes of neurodevelopmental outcomes in the current form of research, not just what's known about if you have Down syndrome, a lot of what they're talking about is the single gene defects and de novo abnormalities, and whether or not we're going to find a signal in there that explains all of the variation that we haven't explained in the surgical outcomes. We think about 10% of single nucleotide variants are inherited and 90% are de novos. But studying genetics is a little bit complicated because if you think of the scheme of everything that drives into neurodevelopmental outcomes, again, this is from the same review article, the genetic factors not only impact the brain development itself, but they impact how you recover someone. Looking at our cardiac intensivist in the room right now, you know when you get a kid back with a genetic syndrome from the OR, how you're going to recover them is a completely different ball of wax than a kid without a genetic syndrome. So it impacts the hemodynamic factors, it impacts their hypoxia and ischemia, as well as the drugs that you have to use in the unit. Some kids are notoriously chew through more drugs to keep sedated. But there definitely is some signal there. So this is from Bruce Gelb's group looking at the single ventricle reconstruction trial and the infant single ventricle trial, where they looked at if you had a CNV or if you didn't have a CNV, and whether you were dysmorphic or not. And again, this is a Bailey score all the way on the left, and you can see it was significantly lower your psychomotor developmental index, and your height was also significantly lower if you had a CNV. And then people like Bill Gaynor have been trying to look at specific genes that they're interested in. So he has a big interest in ApoE2, and he's found a significant signal. Again, this is in the SVR group, and Bailey scores as the outcome. Height also comes out of a lot of these analyses. So we started looking at these data again in a collaboration between in the Bench Bassinet research groups between the Pediatric Heart Network and the Pediatric Cardiac Genomics Consortium. And we're looking at now at 3 outcomes across from left to right: the PDI score, the MDI score, and then your height, your length for HZ score. So we kind of re-looked at these with the bottom being CNVs and the top being just any damaging single nucleotide variant. And we're working on getting this out there, but it's still unpublished, but really no signal if you just broadly look at at these genetic signals and whether or not it impacts outcomes. But if you dive down and look at specific genes, so these are that VIQ number. If you have a blue box here, it means you have a damaging variant in that gene. The yellow boxes mean you have a variant, but it's not considered damaging by the genetic analysis. And if you have a hit in CHD7, JAK1, KMT2D, Notch1, you do seem to have a significant signal. In the interest of time, I won't go into a lot of detail, but I'm really excited about these analyses. That same mathematician I was talking about is into Bayesian network analysis, and it's really getting at sort of that signal to noise question. So what's shown here is a Bayes net that shows the thicker the bar means a higher conditional dependency between the two nodes. So things like preterm low birth weight, there's a big thick bar. Preterm and Norwood ventilator days, there's a big thick bar. But then if you look at the outcomes, and then if you start to put the genetic pieces into it, the contribution of genetics is pretty minimal. So again, we're writing this up right now, but our conclusions as written are that genomic variants explain a small degree of the variance in neurodevelopmental growth outcomes in single ventricle heart disease. But for a few individuals, the variance in high impact genes remain determinative in their outcome. All right, so last area of risk factors I want to talk about is length of stay, prolonged length of stay, and developmental care. So it's been known for a while, research that's been going on for a while. These data are from the Atlanta group a while back, that if you're in the hospital longer, if you're in the ICU longer, sorry to the two intensivists that are here, the longer time you spend with them, the worse your neurodevelopmental outcomes are. So shown here in the graph is the full scale IQ on the x-axis, longer length of stay on the length of stay on the y-axis, longer length of stay, lower IQ. And in multivariate analysis, it's the length of stay that often comes out. So we know that the environment that's required to care for these kids and the treatments may impact the neurodevelopment. And some of that environment may actually be modifiable. But the guidance regarding neurodevelopmental or developmental care in the ICU is really lacking in that 2012 statement. But developmental care has really been adapted in a lot of cardiac intensive care units. So what is developmental care? It's a broad category of interventions shown here, things like controlling the stimuli, bundling cares, family integrated support, non-pharmacologic soothing, cue-based care. And as a cardiologist, I never want to admit that I'm listening to neonatologists, but I have to admit that this is really coming out of the neonatal literature, who have pushed these for a while. And in the NICU, increasing your attention to developmental care is associated with improved neurobehavior, improved weight gain, and shorter length of stay. Close to 90% of cardiac ICUs report efforts to promote developmental care, but there's really a lack of standardization in practice and description. So in the Pediatric Heart Network, we proposed a collaborative learning project where we did a bunch of round-robin site visits across 6 centers, and we all visited each other and looked at each other's developmental care and what they were doing. We learned a lot from each other. Trying to objectify some of it, we used the NIDCAP, which is sort of a standardized assessment that nurseries and NICUs use to get certified in their level of developmental care. Without going into too much detail, there's a lot of different domains. We did self-assessments on them. And a score, like if you're in the 4 range, that's probably pretty good. And in pain, these are just plots of the different domains within the pain categories across the 6 centers that were involved in this collaborative learning project. In pain, most of us think we're pretty good in the cardiac ICU at treating pain. But in caregiving, so things like holding, bedding and clothing, positioning, state organization, we're notoriously really bad in the ICU. And some of that has to do with the length of stay that's in there, the hemodynamic differences between the NICU and the cardiac ICU. But I think we have a long way to go. So we're digging more into looking at different ways to improve developmental care and to change things in the ICU and what is safe and not. These are data from the safety trial that we did for passive range of motion. This is about to launch as an efficacy trial. And we basically showed that it's safe on the day of chest closure and hypoplast right after their Norwood to start doing passive range of motion. There was a high rate of days completed, and we showed initially that there's probably some growth benefit, which is the point of the trial, but we're starting to loop in a lot of neurodevelopmental outcomes to this trial as well, as it's about to launch hopefully this fall. That got us involved in neonatal neurobehavior. And so when I was in Utah, we operationalized the use of the NICU network neurobehavioral scale, which is a way to look at the neonate state regulation. And we consistently found that attention was low. So a lot of different domains were statistically different, but it was attention that sort of kept coming up in the neonatal state. And these findings were corroborated by the Boston group, Sam Butler, and her team. Shortly after we published our paper, she had this outcome. She didn't use the ends. She has probably a more sophisticated one that she does personally, but noted 44 to 53% were, quote, not responsive or minimally responsive to attention and organization. So overall, infants with congenital heart disease, they interact less with their environment because there are abnormalities with arousal, attention, and difficulty with state regulation. So now that we've been building up more and more data on the state regulation and the neurobehavior of these infants, or neonates, we're starting to relate it to the outcomes. This was one of our first takes at that, where we showed that your attention score before you even went to the operating room was associated with an outcome. A worse attention score was associated with a longer time to 100% oral feeds across all of our neonatal surgeries, so not just single ventricles. And we just submitted an abstract that actually now we're showing attention is associated with Bailey outcomes at 12 to 32 months. All right, so those are some of the risk factors. I'm just gonna move on to neurodevelopmental clinics. So in this guideline statement, I think one of the important pieces is point 5.1 here, that you need to take an individualized approach, that every child with complex congenital heart disease is different. And even though in these research studies, we're trying to put them in buckets of this increased risk, that increased risk, you really have to evaluate them. And through my working with, so we developed our clinic there in 2014, and I've had the pleasure of working with a lot of developmental pediatricians and psychologists and therapists, and I repurposed this picture over the last couple of years. I originally used to use it, as I did in the beginning, to talk about risk, because that's often what we do in congenital heart disease. We want to know the risk of death, of ECMO, of failed extubation, of stroke, hemorrhage, seizure. But it's not, when you think about neurodevelopment, the way I've changed my thinking is it's not really just finding a bunch of variables and setting up your analysis to figure out who's at the highest risk for bad outcomes, because it's not all about bad outcomes. There's a lot of gray area in there. And I like to now think about this picture of, you really need to assess the strengths and the weaknesses. And some of the weaknesses will be the risk that that kid has gone through in their course, surgical course and recovery course and prenatal course. But you really need to assess how those risks balance with their weaknesses. And so I like to think about this child on the right actually being a quite motivated young individual. He maybe doesn't have the best influence of an older brother or a father who's just standing there taking pictures, but there's a lot of good in his enthusiasm for wanting to get up that ramp. And to put that in more specific outcomes, so this is an example of 3 individuals that came to our clinic over the course of 2 or 3 weeks. The first was an 8-year-old transposition, had a neonatal surgery, length of stay was 14 days, no major complications. They came to clinic because of academic difficulties. On our assessment, we found their intellectual capacity was fine, their executive function was fine, but they had disfluency and a lot of anxiety related to their speech. The next was an 8-year-old with hypoplastic left heart syndrome, had a prolonged length of stay from a sternal wound infection. They were there pretty much for routine assessment, but had some academic questions. Their intellect tested at high average, but their executive function was extremely poor. And with the poor executive function, they had very aggressive and oppositional behavior. The third individual that came to clinic was a 9-year-old, double inlet left ventricle, right AV valve atresia, malposition, had 5 cardiopulmonary bypass runs, multiple prolonged length of stay. So of all those surgical factors I went through in the previous slides, this is someone that would be a red flag, high risk, lots of concerns. They were there also for routine surveillance, but had some academic questions. And through the half-day testing, nothing remarkable found, no further suggestions at this time. So here you have 3 individuals around the same age, one where we uncovered issues with speech, one where the root of the problems were behavior, one where there were no concerns noted, but they all manifest in the same issue in these 8 to 9-year-olds, which is difficulty in school and academic troubles. And so you really need, that's where I get to, you really need to evaluate the strengths and weaknesses, what the kids are struggling with in order to promote how they can best go out and attain what is wanted in school. So the Cardiac Neurodevelopmental Outcomes Collaborative has sort of been in process since 2010, but officially formed and incorporated in 2015. It's a group of now close to 40 centers with a vision. It's really, what I really like about this group is it's very multidisciplinary. So it's physicians, it's therapists, it's psychologists, neuropsychologists, nursing, a lot of groups coming together just to see what we can do to optimize neurodevelopmental outcomes. Again, about 40 centers, hanging on to that one in Europe, mostly across North America though. And I'm happy to say Maine Medical Center, as of a month and a half ago, is now a CNOC member, which means all of you are actually members. So it's an institutional membership, and I encourage you to take advantage of it. Talk a little bit about that at the end. And that's the website for CNOC. But as we started to work together in CNOC, and a lot of it's how do we focus our research, how do we get at what we need to study, we're also just seeing how people are doing things differently. And with approximately 40 centers, I think there's 40 different approaches. So these data should be out soon. It's impressing cardiology in the young. The bar graphs on the left show, we just surveyed sites to what tests in the recommended CNOC testing battery, which is all those tests listed on the bottom, what they did routinely, sometimes, and never. And you can see there's a lot of variability of the actual tests that people use in their clinics. And then the one on the right, we want to get an idea of routine clinic, what people were anticipating the kids coming back to. So we just looked at the schedule. Like if everything was going great, when did you see kids with, and when you reached 100%, that's when you're kind of done. And you can see there's a big issue with our centers overall in that everyone is really focusing on the birth to 3. When you talk to people individually, they're saying, well, we're building our programs as with this cohort, and then we're going to grow our programs as this cohort gets older. And a lot of that's kind of data driven because they want to be able to follow them with the surgical variables starting out earlier, and then they want to follow them later. Part of it is it's a lot easier to identify kids as they leave the hospital. That's what we did in Utah, and set them up for return to clinic automatically, as opposed to get all the cardiologists to remember to refer them when they're 5, 6, 7 years old. And across the country, we're all very bad at adults with congenital heart disease and what we're doing for their behavior and neurodevelopment. Just to give an example, this is what we did in Utah when we developed the program. We had anticipated 4 screening points where no matter how you were doing, we would evaluate you. One was, I already talked about, the neurobehavior evaluation, inpatient consultation. As you come back at 18 to 24 months, 4 years of age, we called that sort of the school readiness evaluation. The 18 to 24 months, I called it's kind of when they were starting to get discharged from early intervention, but they shouldn't have really been discharged. And then 10 to 12 years of age, I called the executive function visit. So there are a lot of kids that seem to be doing fine, or they're doing fine. And then when they start getting pushed in middle school, that's when you started to really notice some deficits. And the tests that we did and the disciplines that were involved are all listed there. I won't go into them. We found, though, that we had a huge bias in who came to clinic. So some of that's based on perceived risk, I think. And so in this paper, we showed that a lot more hypoplast and coarcts come back to clinic. And I think that's because everyone talks hypoplast over and over again. They're plugged into all these interstage clinics, and everyone knows my kid has hypoplast, that hypoplastic left heart syndrome, that they're at risk, and I'm taking advantage of everything the Heart Center has to offer. Whereas we probably don't do as good of a job talking about risk of neurodevelopmental abnormalities with coarctation. You go home in a couple of days and you may not need another surgery the rest of your life. We also found there was a huge bias in who your cardiologist was. So the graph on the right is each individual. There are about 30 of us in Utah. And we found 48% of our clinic volume came from just 5 cardiologists. And so that probably shouldn't be the case. The other piece that's in this paper that I won't go into, or that I don't have a diagram for, is we estimated if you take the 2012 guidelines of who's at risk, we saw about 5% of those at risk. The only other group to publish, even though a lot of people claim they have numbers on it, Michigan group, and they, with a slightly different approach to the denominator, published 20%. It's really a big focus of CNOC right now, is to get at the denominator instead of just the numerator of who's coming back. So I was interested in that when I got to Maine, and I have to thank Adam Black for pulling these data. He's with the Center for Outcome Research. What we did is we looked at the all-payer claims data for 2015, 16, and 17, just to try and put on the scope of how many unique individuals are there in the state of Maine accessing care. And so these are the number of unique individuals on the y-axis with different decades. On the x-axis, it's claims data, so whether or not there are 90-year-olds with complex, and the codes were complex structural heart disease, so whether or not they're truly 90-year-olds or there's some upcoding out there, I don't know, but you get an idea of where where the distribution of people are. And then what Adam did for me was pulled any CPT code that we typically build for in our neurodevelopmental clinic. So I don't know where these evaluations are occurring or by who or if they're out of state. But we pulled the CPT codes on the right, and we saw that, again, the ages are on the x-axis there, and then percent on the y. Maybe 10% of kids are getting some sort of more in-depth neurodevelopmental evaluation, which is actually better than I anticipated for these data. So it brings up how do we think we can approach reaching more children, and not only in Maine, but across the country. The COVID pandemic has really forced the possibility and the issue but potentially the benefit of telehealth. And so I was lucky to chair a telehealth task force within CNOC with Adam Cassidy from Boston Children's Hospital. And as CNOC members, you guys all have access to the report once we send it out. But these are just a piece of the data from a site survey, seeing what people were doing. And the blue shows telehealth things that you were offering before COVID, orange, new service offered in response to COVID, and the yellow, not offered at all. And you can see people have really ramped up across the country, being able to do interviews, being able to discuss results, as well as maybe some focused interventions via telehealth. The testing there's some sites that are really pushing it, and some psychologists are really excited about it, but we have a ways to go. But if you look at the percent that have the psychology encounter across the state of Maine, there's definitely a regional issue that we see with the areas that we're reaching. And so as we think of developing, or as we're developing the Congenital Heart Neurodevelopmental Program here at Maine Medical Center, the first step I think we would like to do is really leverage the telehealth advantages and combine that with an approach that we know is currently a deficit at other centers that have big multidisciplinary full day or multi-day clinics, where we're not capturing as many people as we need to, and we're probably not filtering for those at the highest risk compared to just all comers, as you saw in the earlier graphs. So what we're proposing to do, and hopefully going to start this fall, is we're going to identify all patients that meet high-risk criteria just based on 3-month recall blocks in congenital heart. That'll prompt an initial contact letter to those families about the program and about the general risk associated with congenital heart disease. And then a social worker will do a telehealth intake visit that'll include checking on needs, inform the family of new psychosocial services, and then send a screening link to complete some forms and document that visit in Epic. And then we're really going to rely on parent and patient-based questionnaires, namely the BASC, ABASC, and DASS that I'll talk about in a second. And then those questionnaires will be done remotely. They can all be done electronically. And those will be reviewed by our psychologists and then prompt a telehealth psychology visit, but it'll be close to the time that individual's coming back to congenital heart for their cardiology visit, so they can be seen in person as well. And that may prompt additional referrals and assessments as indicated. So I'm really excited that we have on board Brianna Costello, our social worker, and Julia Price, our psychologist, who have been spearheading a lot of this effort and are going to start telehealth visits hopefully soon. So real briefly, the patient and parent questionnaires are a validated part of the CNOC battery. The BASC has subscales and adaptive and problem behaviors, takes about 10 to 20 or 30 minutes. The ABASS is an assessment of adaptive skills across the lifespan, takes about 15 to 20 minutes. And then the DASS, this is where I think a children's hospital and an adult hospital can really push what other large children's hospitals haven't been able to do. We all know parental mental health is a big issue driving the neurodevelopmental outcomes, but everyone's hesitant to screen because they don't have ways to follow up if they're in an isolated children's health system. And so the DASS screener, which is a depression, anxiety, stress scale, is on the CNOC battery, but approximately 0 centers are using it because they're not sure how to document. So we think we've worked around that. We figured out how to do it, and we're going to screen parents and caregivers and with reflex to additional testing and support as needed. All right, so in summary, individuals with congenital heart disease are at risk for impaired neurodevelopment. There's abnormal brain development, and it starts before the operating room. Common areas of concern for these children include neonatal attention, motor development, executive function, and visual motor integration. We've identified a lot of risk factors by studying a lot of cohorts, but really, in reality, every child charts their own course, and risk factors describe only a small amount of the variance in the outcomes, and therefore an individualized approach is really critical to assess the strengths and weaknesses and support development of these kids. There's a lot of variation currently in heart-centered neurodevelopmental clinics across the country with low capture rates, and we're really excited to start the Congenital Heart Neurodevelopment program in 2020 to identify more at-risk children. And the last plug is you are all now members of CNOC. Just like everything else, the meeting is now virtual, but it's November 18th to 20th. You can go to cardiacneuro.org. The other big member benefit of this group, if you're not delving into the research, is there are these things called special interest groups, which are really almost like our collaborative learning project. There's a neonatal group that's just talking about neonatal care in the ICU. It's driven a lot by nurses and therapists and feeding team people. There's just a lot of collaborative learning in these what's called SIGs, or special interest groups, that, as members, everyone is privy to at this point. Thanks. Mute it now? What do I do? Oh, I can't see that. I just end slideshow.
Yeah.
And I can see.